Hello, and welcome to today's webinar, COVID-19, Approaches for Optimizing HIV Prevention and Treatment. I'm Dr. Oliver Brooks, President of the National Medical Association, and I'm happy to have you here today for our webinar. This is the third in a series of Saturday webinars hosted by the NMA, the first being an update on COVID-19, the second, COVID-19 and vaping. Representing the nation's 50,000 African-American physicians and our African-American community, the NMA is committed to keeping its members and the community up to date on COVID-19 in general and its effect on disease-specific conditions such as vaping and HIV. We also have a Facebook Live every Thursday at 8 p.m. Eastern. I also want you to note that there is a joint statement between the NMA and the Rainbow Push Coalition on our webpage under Latest News. We have partnered with Rainbow Push and focusing on certain areas, including treatment, testing, prevention, and then protection of vulnerable populations such as the prison population. So please take a look at that joint statement. There is also a podcast with performer T.I. interviewing former Surgeon General Regina Benjamin. You can find the link on our social media, including our Facebook page. Now, for today, I have the distinguished honor to present our moderator for today's webinar, Dr. Virginia Kane. Dr. Kane earned her MD degree from New York Upstate Medical Center, completed her residency in internal medicine at University of Cincinnati College of Medicine, and her fellowship in infectious diseases at the University of Washington School of Medicine. Presently, she is the director and chief medical officer of the Marion County, which is Indianapolis, Public Health Department, and she is associate professor of medicine at the Indiana University School of Medicine, Infectious Disease Division. She is past president of the American Public Health Association. Dr. Kane set up the first nationwide physician education program regarding AIDS, and later this was duplicated by the AMA. It was set up for the NMA. There's much more to her extensive bio. For example, being on the editorial board of the Morbidity and Mortality Weekly Report, the MMWR, a very respected document publication from the CDC. I will add one item not in the presented bio, however. She is the immediate past chairman of the board of the NMA and has brought to the NMA many grants, which is very important for our operations. I present to you our moderator for today's session, known affectionately to us as Jenny, but I present to you Dr. Virginia Kane.
Thank you, Dr. Brooks. I appreciate that introduction.
You have a little echo there, Dr. Kane. Please adjust.
Okay. Let's see. Wow.
You're good. You're good.
Thank you, Dr. Brooks. Can you hear me?
Yes, we can.
Okay. Well, let me just say, this HIV has cost America too much for too long. And without interruption and despite our substantial progress in regard to the HIV epidemic, another 400,000 Americans will be newly diagnosed over the next 10 years unless we do something. But with this unprecedented new viral disease, coronavirus, and the social distancing, we have seen a number of medical clinics be closed or not available for prevention or treatment related to HIV. And so I'm delighted that we have a distinguished panel of experts who will provide you worthwhile approaches for optimizing prevention and treatment for HIV. And let me start out with our first two presenters who are going to do a combined presentation, and I'll begin with Mr. Douglas Brooks. Mr. Brooks has served as chair of the Board of Trustees of AIDS United in Washington, D.C. And because of his advocacy, he was named and appointed to the Presidential Advisory Council on HIV/AIDS and subsequently named as the body's liaison to CDC's HRSA Advisory Committee for HIV. And in 2014, he was appointed as the director of the White House Office of National AIDS Policy. And he helped to spearhead the first update to the National HIV/AIDS Strategy, a 5-year plan that served as the framework for the nation's response to HIV, focusing on people of color, transgender men and women, plus supporting a widespread scale up of PrEP as a key critical factor to reduce new infections in the United States. He currently serves in his new role as Senior Director for Community Engagement at Gilead Sciences. Combined with him as speaker of their presentation, our next expert is Dr. Gina Brown, who joined the medical staff affairs team at Gilead Sciences as a principal medical scientist for the New York region. She is an obstetrician and gynecologist with an extensive experience in HIV clinical and research. Before coming to Gilead, Dr. Brown was a medical officer in the NIH Office of AIDS Research, where she conducted HIV research on non-vaccine biomedical prevention, including PrEP, women and girls issues and comorbidity. And prior to her joining even that Office of AIDS Research, she was a member of the NIH Office of AIDS Research Advisory Council, and she chaired the Advisory Council in 2004, really focusing on a lot of women and girls episodes. A prolific researcher, I'm delighted to present both these speakers for their following presentation in terms of giving us a background overview in regard to disparities in health. Mr. Brooks.
Thank you, Dr. Payne. I'm really excited to be participating on this webinar today. I'm watching the count go up with over 110 people listening in today. And one of the first things I'd like to say is that we at Gilead are tremendously excited about our partnership with NMA following your meeting in Hawaii, where we got to spend a lot of time together with you and Dr. Brooks and others on the staff and on the various boards. I think the fact that we're having this first webinar and engagement so quickly, and we would have had it even sooner if we didn't find ourselves in this situation, because we were going to meet at your health colloquium. But we want to thank you both for saying yes to engaging with us, to doing this important work for the people that we love and we serve, and for having this today. When we were rehearsing earlier, Dr. Brooks asked us to remember that we were in fact talking about HIV, but that we're talking about it in the context of COVID-19. And that reminded me of something that I'd written a few days ago. I read a piece from a guy who was suggesting, and I think rightly so, that he didn't think we could compare COVID-19 to the onslaught of AIDS, of HIV in the US, and that it was near sacrilegious to do so. And because the governmental and societal responses were just incomparable. And, I don't refute those facts, they're facts, but there are similarities. And So when we look at the initial denial, when we look at the fear of each other, human beings fearing each other, when we look at the fear of connection, of human connection, which is so natural, when we consider the horrific, isolating death that people experienced, and even as we think about the resignation to getting it, to becoming infected, and certainly the trauma that results from both things, the desire to get back to normal. And then, you know, as we think about us, the late understanding and acknowledgement of the impact of Black lives from which we are still trying to recover, and unequal care and resources. So I do think there are several ways in which we see these things happen. On the morning after the press briefing, where my friend Dr. Tony Fauci spoke and said that when this is all over and we will get past coronavirus, there will still be health disparities, and we really have to think about the African American community. Thought it was really powerful. What was equally as powerful for me was I got a text from a friend in Atlanta, happens to be a white guy, but he wrote, "Surprise, said no Black person in America," when the US disparities were cited and related to COVID-19. And I thought, well, there you go. And so we continue to see these disparities throughout the country. You've heard about them. I'm not going to go through every one of these bullet points, but even if you just take a look at Michigan, where 1/3 of the positive tests are among Blacks, but 40% of the deaths are among Blacks. And in Louisiana, where about 70% of people who have died are Black, though only 1/3, sorry for that typo, of that state's population is Black. And then we ask ourselves, what are the factors that are leading to these COVID-19 disparities? And we've heard them, underlying health issues like diabetes and heart disease, structural factors like the fact that African Americans have lower rates of health insurance than whites, and everything to which that leads, late entry into care, late arrival into hospitals, the greater likelihood of dying, and then where we've been asked to isolate and stay home, Black Americans are disproportionately belong to parts of the workforce from which working from home is not an option, and that places us at higher risk for contracting the infectious disease in transit or at work. And then finally, even thinking about intergenerational households, which Black and brown people tend to have more. Young people get infected, they seem okay, but then they end up passing it on to their grandparents. Someone is not muted. When we think about racial disparities in HIV, African Americans are more likely to be impacted than their white counterparts. While Black Americans only represent 13% of the population, we represent 41% of incidents and 43% of all new diagnoses. And while we see infection rates dropping, among a lot of people, we see it increasing in Black men. Black women are much more likely to be diagnosed with HIV than white women. In the Midwest, as much as 18 times. In the Northeast, 21.9%. And then similar in the Southern US, the disparities for all of our people, for Black women, for Black, gay, and bisexual men, are just simply off the chart. Can you advance the slide? For some reason, I can't move my next slide. Thanks. I won't take up a lot of time on these. We at Gilead work in several areas. And as I was thinking about this presentation, I just thought, well, let's just take a look at the disparities not only in HIV, but in inflammation, in cancer, oncology, in liver disease like HCV. So while 90% of people living with lupus are women, African American women are 3 times more likely to have lupus. African American women often suffer from lupus at a younger age and have more symptoms. Even in this age of COVID-19, where we see the demand for hydroxychloroquine, which is a drug that is used to manage lupus, and there was a rush on that drug. We found many Black and brown lupus patients without access to their medication. Next slide, please. Similar in colorectal cancer, and I'd like for us to really pay attention to how some of these themes keep popping up, that some of the disparities, underlying conditions such as obesity, increased risk for things like colorectal cancer, as well as COVID-19. The insurance issue pops up again for us. And so all of these social determinants of health have an impact on our care and access to care and quality of care. Next slide, please. And then also, as we look at HCV, we see similar disparities. And you look at the fact that sickle cell is prevalent in the African American community. We didn't start screening for HCV until 1992, puts older African Americans at risk for HCV. We're 5.9 times more likely to be incarcerated, where we find great disparities and disproportionate impact of HCV as well. And then we're still missing adequate education and training for HCV as well. I think, I think that's my last slide, yes? I wanted to wrap up though by thinking about the importance of our lives from a systems perspective. I'm not a doctor, not a physician, I'm a social worker, but the systems perspective from which we operate is actually derived from biology, and it calls us to be reminded of the interdependent and interrelated aspects of human existence. We call it biopsychosocial, and I always add spiritual. And we need that framework, I think, to understand both the barriers and the disparities, but also to consider the facilitators for lives. I'm the product of African Methodism, and I am taught as early as I can remember that our story is not just a veil of tears. It's one of great resilience and one of the great stories of human resilience in the human history. And out of the bondages of slavery, we've done some amazing things. We've built African Methodism itself, institutions of higher learning, corporations, communications, conglomerates. And I hope that as we move on in this conversation and it up to, we also think about the ways to advance the health and well-being of our communities using the great skills and knowledge and experiences of resilience that we have. So I'm going to turn it over to my sister and colleague, Dr. Gina.
Good morning and good afternoon to everyone. Thank you for taking the time out of your Saturday to do this. You can feel the passion for both Douglas and I, and likely the many of us who talk about this on a regular basis, of how important it is for us as care providers to the Black and African American community to really understand what our issues are, but also to take charge of how to make sure that we care for our people appropriately, and even to make sure that our people get the appropriate care, even if we're not the people delivering that care. this is a real opportunity, I think, for all of you to take home a better understanding of the disparities that we often talk about in HIV/AIDS. We're only just starting to talk about this with respect to coronavirus or COVID-19 infection, but to recognize that there's a stream that has followed throughout about these disparities, that we always fall to the top of lack of access to care, often the worst of the way the diseases are represented. So I'm going to walk you through HIV and the impact it has on our community. I'm going to make some relationships to how this actually is mirrored with COVID-19. So this shouldn't be a new thing for us to recognize that there's a disparity within COVID-19. And again, as Douglas Brooks showed you, this has been a true story throughout many other illnesses. But I also want us to end on a sense of what it is we can do, how we take our collective strength, our collective abilities to have an impact on this and provide the best care possible for people who look like us. If you look at the diagnoses of HIV infection among adults and adolescents in the United States, and you break it down by race and ethnicity, and as Douglas said, we are tremendously overrepresented, and that is true whether it's the Northeast, the Midwest, the South, or the West. In purple, you can see African Americans. The next greatest group is Hispanic or Latino or Hispanic Latinx individuals, and very far down compared to white and orange. And so across, no matter where you live. And the other thing I want to point out is we talk about this brand new epidemic in the South, and it's been bubbling up for a long time. New diagnoses in HIV are 52% from the South, whereas the population is only about 38% from the South in the United States. So the South is actually as well overrepresented. But please do not ignore that across the board in each of the regions we live in the United States, African Americans are overrepresented in terms of new HIV infections, in terms of diagnoses of people who are living with HIV. And so we as providers have an opportunity to work on both prevention and making sure that there's a holistic approach to treatment for African Americans. The other thing I want to point out is that picture that we get from the Centers for Disease Control doesn't fully tell our story. It doesn't fully tell our story. So when you break it down in terms of rates of HIV per 100,000 of the population, you can go to, and I could go to like state by state, but I'm giving you the top 5 that show that it has a much greater impact. So if the overall US rates are 367.6 per 100,000, and that includes Black, white, all, when you break it down to African American rates, you can look at DC where it's 460 basically per 100,000 overall. But there are even neighborhoods in DC that you can go into. In a zip code in Anacostia, it's as high as 8,900 per 100,000. So instead of 367, it's as high as 8,900. You can take New York, where it's about twice the rate of the national rate among African Americans. And you can look at the rate in a neighborhood in the Bronx among African Americans, where it's 18,000 per 100,000. So you can see that if you can break it down to zip code and to particular neighborhoods, this 367,000, which is nothing to ignore, doesn't even begin to tell our story. And I could do this for almost every state across the nation where this data is reported to show you that we are fully overrepresented in particular areas where even, all of DC, impressive, but the Black neighborhoods in DC are more than impressive in terms of the effect. The same for New York. This Maryland is the area in Baltimore, and it goes on and on. So it's important for you as providers to pay attention to what's happening to not just where you work, but where the people you service come from, to have a full recognition of the impact in our Black and African American communities. Whoops, we need to go back. Let's see. It's a rather fussy little thing. So there's been a lot in the news in the past year about ending the HIV epidemic, a plan for America, as though it's a very brand new thing. And so Douglas, he was the director of the Office of National AIDS Policy, and he not just spearheaded the plan that we're currently working under with the new plan about to take place after 2020. But he also spearheaded this concept that we work with all of the different governmental agencies working as a partnership, and we developed a plan that showed that partnership, but it also required that we demonstrate all of the different communities and community-based organizations that we worked with. So it was from the ground up and from the top down and broad to ensure that we weren't just levying a plan upon America, but we were working with communities to ensure that they are part of understanding what the plan is, and also working hard with us to get to decreased numbers. So the goal is a 75% reduction in new HIV infections in 5 years and at least a 90% reduction in 10 years. And part of the goal is to diagnose all people with HIV as soon as possible after infection. And that's a real opportunity for you as providers, where an HIV test becomes part of regular care. Just like you're going to test for a hemoglobin A1, you would test for HIV when someone comes in to see you the first time. Just like CDC recommended doing hepatitis C for all baby boomers, and now even for younger age groups, HIV should be part of the natural care that you would give to somebody on their roughly annual visits. And then getting people hooked into care and getting treated as rapidly as possible. Because we know that if you can get a person with HIV treated, the medicines are a lot easier. Many of them are one pill once a day, that you can keep them from getting the other illnesses that are associated with HIV, and also give them a lifespan that's essentially not any different than they would have had anyway. In addition, we also know that for COVID-19, that if a person has HIV, it doesn't necessarily put them at risk for a worse outcome if they have fully treated HIV infection, where their virus, the amount of virus that can be detected in their system, is undetectable. So a full treatment regimen that's effective can actually help someone who ends up getting the COVID-19 infection. And we can also protect others from getting HIV infection, and I'll talk a little bit about the level of disparity in pre-exposure prophylaxis, or PrEP as it's called, and also the opportunities for you guys to learn more about implementing PrEP in your practices, because in addition to where you may not see HIV infected patients, you can get people referred for care. You can also keep the patients that you have who are at greater risk from becoming infected with HIV. So the target areas for this plan to really implement, if you remember the first map I showed you where you can see that, and actually I'll go back to it for a second so you can look at it again, where these dark purple areas are the places with the highest rates of HIV infection in the United States. So the Northeast, all along to the south, and then on the West Coast. This is where these target areas are for the implementation of this plan, these really focused areas, looking at the highest burden counties. But it doesn't mean that we're ignoring HIV in other places that you all may live and work, because there is HIV there, but this is a lot of where the funding has gone for the HIV epidemic. It's an opportunity for all of you to take advantage of the funding that's available through the Centers for Disease Control, to take advantage of the funding that's available and the opportunities for education through the AIDS Education and Training Centers. You have Gilead medical scientists who can provide you with the education that can help you with both treatment and, importantly, help you with the prevention of HIV infection. And if you look at what we've seen in the news lately about COVID, you can also see that these are the places where we're seeing a lot of new COVID infections. Concentration along the Northeast, along the South, and Douglas talked about a number of the reasons why we're seeing this, particularly in African-American communities. It's places where people are concentrated in terms of where they live. And it's also places where folks may be living in multi-generational households. And it's places where people may or may not have adequate access to care, adequate insurance, living in neighborhoods with food deserts where there's not a great grocery store, an easy place to shop, or a place to be able to walk. So when we talk about the associated illnesses like diabetes, hypertension, all of the comorbidities that are associated with being Black or African American, we often say, well, if they just didn't eat so much, or if they just took a walk once in a while. Well, you've got to live in a place where you can take a walk safely. You've got to live in a place where it's not easier to get to McDonald's than it is to get to a decent grocery store. And you also have to live in a place where you can get around. You know, in New York, you take public transportation, and the subway is one of the biggest concentrations of opportunities for people to get infected. I get to stay home from work and get paid. Many of the people I see out in the world, out in the streets, look like me, are on the subways, on the buses, trying to get around and get to work so they can still get paid. So it's not just the things we do to ourselves, but it's often the situations in which we live and work and are able to support ourselves. So there are opportunities to prevent HIV infection. Again, if you're identifying a person with HIV and they're referred and get treated appropriately, there's, to the left, treatment as prevention, which is a fully functional treatment regimen that keeps their viral load, meaning the amount of virus that can be detected in their body, down below detectable. And if that is true, we know that when they have sex with others, they will not pass the virus on to another individual. So it's known as U equals U, or undetectable equals untransmittable, is the campaign. But treatment as prevention has been well documented many times in different populations that it works. So it behooves us to identify folks with HIV and to make sure they get treated. The other opportunity we have is post-exposure prophylaxis. Someone has a risky interaction. They have sex without protection. Someone is sexually assaulted. Someone doesn't know, which is very often the HIV results of any of their sexual partners. They can get, if they come to you within 72 hours, you can give them a full regimen of antiretroviral therapy for 1 month to keep them from getting infected. If you have an individual who has other reasons to be at risk for HIV infection, or when they finish their post-exposure prophylaxis, that full regimen after coming to you within 72 hours, they can be treated with PrEP. So you may see someone who has, we all see people who have sex, and that is a standard. You may treat or see someone with a sexually transmitted infection. You may see people who've been just out of prison or out of jail, and in order to have a place to sleep, they're, you know, on somebody's couch. Or you may see people who live in neighborhoods where there's a lot of HIV, so they're much more likely to come across someone with HIV infection when they're having sex. There are lots of different reasons, but you have an opportunity to provide them with pre-exposure prophylaxis. It's a 1 pill once a day regimen. We have 2 pills, Truvada and Descovy. Descovy for men who have sex with men and transgender women. And then the studies are being done on that to look and see its effectiveness in women. But we still have Truvada that's available. And you can get additional education on all of this, working with your AIDS education and training centers, working with your Gilead medical scientists who can come into your offices and spend a little bit of time just giving you the information, giving you the data, and hopefully making you a lot more comfortable for being able to manage the prevention of HIV infection in your patients and also the maintenance of their health. But what I want to point out to you is, for having this information that can help us prevent HIV in our community, which is at greatest risk for HIV infection, look to the left. You can look at our population distribution by race and ethnicity. We're about 13% of the US population. In terms of HIV diagnoses, we're about 44% of the population being diagnosed with HIV overall. And it's an even higher level if you just look at the population of women, and a slightly higher level when you look at the population of men who have sex with men. But if you look at who's getting prevention, we're totally underrepresented. Only about 10% of us are getting medication for pre-exposure prophylaxis. So small part of the population, large part of HIV diagnosis, very small part of pre-exposure prophylaxis. This same sort of thing is mirrored when you look at the coronavirus infections or COVID-19. We're still only 13% of the population, but in places like Chicago, where we may be 30% of the population, we're 70% of the people with COVID-19, and we're also about 45% of the individuals who are dying from COVID-19. Even in New York, we are about 20% of the population, but we're 29% of the persons who are getting infected with COVID-19, and about 45% of the individuals who are dying. So much more overrepresented in all of these populations. And we need to know this. The other overestimate I want to talk about is that we have seen this in all of the illnesses Douglas talked about. We've seen this in HIV forever. And it's only been in the past 2 weeks where people are saying, oh, we should look at the information on COVID-19 by race. That should be a standard for any of the illnesses that we're examining. We shouldn't be a second, third, or ninth thought about, oh, that's a possibility. We really do need to think of it in terms of how we formulate prevention. So we have a partnership with NMA right now. We have a Gilead partnership, but I think we can expand that partnership to all of the providers. We have a partnership with the NMA leadership. We identified local and regional leadership as well. We're identifying people who are interested in working with pre-exposure prophylaxis. But what I mean is this partnership that lets us start both on the local level, getting to the medical section level, and collaborating with the NMA for education at national meetings, but also increasing, in this case, PrEP knowledge, support, and use. But this same model of working from local to regional to national can be used for COVID-19 as well. And this is some of the beginning parts of that. I'm going to finish up with a little bit of the COVID timeline. First heard of in December 8th with about 40 cases in Wuhan, China. It was considered to be an outbreak. They identified the virus in January, and then they started seeing the virus outside of China, so it was becoming an epidemic. You were seeing it outside of one local area. And when this slide was made under a month ago, on March 25th, there were more than 400,000 cases in the country and about 19,000 deaths. There are almost 3 million cases, I mean, not in the country, in the world, almost 3 million cases in the world. And there are almost 200,000 deaths. And that's in about 30 days, little less than 30 days time. If you look at the United States, we're up to almost 3 million deaths. I'm sorry, we're up to almost 3 million cases, and we're up to more than 50,000 deaths. So in 30 days time, this is how much this disease is spread. And this is why it's important for us to intervene and protect our communities. You know the basic clinical presentations, but what I want to point out the similarity with HIV is very few patients, only about 20%, have that severe or critical. We're missing a whole lot of people who are infected and maybe undiagnosed or underdiagnosed. The same issue with HIV infection. There are people with HIV who are not symptomatic, very few are symptomatic. And it's important for us to get in and do prevention before people are at that severe critical stage, and to identify individuals at risk so we can help with prevention. With COVID, we don't have medication to treat. As you well know, sunlight and bleach certainly will not do it. And you may think it's bizarre to mention this, but patients watch the news, they go online, they pay attention, and it's our obligation as providers to preemptively introduce and explain how you can prevent this for yourself, and to help them understand that this is not the time to be thinking about bleach and other disinfectants that are used for cleaning, to really educate our patients. And I think that's the role we as providers have for both COVID, but also for HIV. So what we have for COVID is social distancing, staying away from others, avoiding crowding, using masks. There are a number of places around the country where you can't go out without a mask, the travel advisories. And we as providers have to both mirror that, but also explain that to our patients. Much in the same way we had non-pharmaceutical interventions for HIV where we talked about safe sex, we eventually developed pharmaceutical interventions for prevention, and we will get there. The current research that's happening is looking at a variety of medications in controlled trials, and we need to wait for those controlled trials to come forth. A lot of what's been presented in the media are not controlled trials. And of course, ultimately developing a vaccine, which is hard, which is long, but there's some tremendous work being done. There's this amazing young African-American woman, 33 years old, who's spearheading the vaccine research at NIH, who needs to be recognized by all of us for the tremendous work that she's been doing. So I'll finish here and just leave you with our charge is to educate our patients, to work with our patients, and to recognize that we have an opportunity to, in addition to recognizing our increased risk for things like COVID and for HIV, to use prevention when it's available, and if there's medication prevention, to recognize when the opportunity to use it to prevent HIV infection, but also to educate our patients about HIV prevention and then the non-pharmaceutical interventions that will help prevent them from getting COVID. Thank you.
Thank you, Dr. Brown and Mr. Brooks. for your wonderful presentations and the information that you provided to all of us. And hopefully we'll have some stimulating questions at the end of our presentations later in the webinar. Our next speaker is Dr. Downer, who is an associate professor in the College of Medicine at Howard University. She has served as a principal investigator and project director for the Howard University's Caribbean Clinicians Preceptorship Program, as well as being the former head of HRSA's National Minority AIDS Education and Training Center, which we call MATEC, and also head of the Capital Region Telehealth Training Center for more than a decade. She is currently being directly funded by the National HIV Curriculum Integration Project. And this project is aimed at strengthening the HIV clinical workforce at 14 historical Black colleges and universities and 28 of their health programs. So she's done a lot of training and also has a lot of expertise in the role of cultural competency in emergency management. And wow, do we have an emergency right now with the COVID-19 and how telehealth is playing now a more critical role in terms of educating our patients, educating our clinicians, because they may not have access to a walk-in clinic where they can access information. So Dr. Downer, we are very interested to hear about how you're helping our clinicians across the country and even out of the country. Thank you.
Good afternoon, everyone. I've been asked to address telehealth in the wake of HIV and COVID-19, and will focus my comments on Howard University College of Medicine's work for almost a decade in using this technology, both here in the US and internationally, to strengthen our workforce. I'm getting my slides available. There we are. We hear a lot about how HIV and COVID-19 disproportionately impacts our African American communities. That fact is irrefutable. One of the best ways to reduce the inequities of these and other diseases is for our clinicians to stay up to date and be well informed as we constantly juggle competing priorities. Now, one of the vehicles available to us to accomplish just that is telehealth. With this technology, we can marshal our resources to be effective clinicians as we care for our communities. The implications for strengthening our clinical workforce and an approach to optimize prevention and treatment is one outcome of this technology. Now, some people use the word telehealth and telemedicine interchangeably. So let me pause here and define each word, and in doing so, ensure that we have a common understanding for the operational definition of this presentation. Telemedicine is the practice of medicine, using technology to deliver clinical care at a distance. So in its broadest context, telemedicine refers specifically to providing clinical care while treating patients remotely. Telehealth, on the other hand, refers broadly to the use of electronic and telecommunication technologies to share information such as provider training, to include medical education, public health, and administrative services at a distance. Now, depending on your geographical location, over the past decade, clinical services have been included in the telehealth portfolio, but this aspect is not the focus of this discussion. So what telehealth allows, or rather telehealth allows us to do, for example, is to educate our workforce on the best possible clinical care and on research. We offer, for example, didactic CME-approved advanced training topics, case-based trainings that are meant for discussion areas that may not have necessarily been covered in didactic training. We're also able to conduct effective, culturally appropriate consultations and also identify clinical challenges, then provide ongoing technical assistance. These are just some of the aspects of the training using this technology. Whatever terminology we use, the important outcome for both telehealth and telemedicine is to improve patients' health. Now, we know that the technologies for telehealth have existed for several decades at varying levels of sophistication and with only modest uptake. But its uptake has increased exponentially as COVID-19 gives telehealth widespread acceptance as the virus expands its siege across the country. Our preliminary data show that many clinicians who were previously skeptical no longer remain so. We will continue to collect data and share usage with you at a later date. I want to talk here about Howard University College of Medicine's work in telehealth. The university, at the helm of several previously funded national training centers, to include the National Minority AIDS Education and Training Center, the AETC National Multicultural Training Center, and the HIV Capital Region Telehealth Center, has educated over 70,000 clinicians nationwide in HIV and cultural competence over the past 2 decades. Almost a decade ago, the federal government funded the College of Medicine to specifically develop and establish the Capital Region Telehealth Training Center. This distance-based technology was used to educate almost 1,000 clinicians in Virginia, DC, Maryland, and Delaware for over a 3-year period. In 2018, the Health and Human Services reported that the number of HIV clinical providers is declining nationwide. This, while the demand for the services is increasing, and their data show an estimated shortage equaling roughly 30% of the actual supply of HIV clinicians. The data specifically showed that this shortage of well-trained HIV clinicians was attributed to several factors. These include that many first-generation HIV clinicians are retiring from practice. Recruiting HIV care providers is a challenge as young providers choose medical careers outside of HIV and primary health care. Also, young providers are not adequately exposed to HIV training during pre-professional education. Furthermore, HIV medicine is not taught in many health professions' academic or training programs because it's generally not required by school accrediting agencies. In addition, the majority of patients with HIV are seen in outpatient clinics, so fewer students are exposed to people with HIV during their residency programs. Not only that, they do not manage sufficiently large caseloads to hone their skills in HIV treatment and care while in the clinic. In fact, one researcher who conducted a survey of first-year internal medicine residents found that greater than 50% of the students felt their residency programs had not adequately prepared them to practice HIV medicine. As a result, many clinicians pursue medical careers outside of HIV. The National Map of Health Professions Shortage Areas indicates the shortage is particularly acute in urban areas, not necessarily densely populated, but urban areas in general, and in the deep south, where HIV prevalence, as we've heard from my colleagues earlier, is higher. Now, we can all agree that the intersectionality of HIV and COVID-19 puts into perspective the complexities of not just HIV in a vacuum relative to quality care, but also how to address emerging disease threats. Howard University is one of 2 academic medical centers to be awarded a 4-year, $2.4 million grant from HRSA to establish and direct the Howard University National HIV Curriculum Integration Project. The award was granted in 2018. The purpose of this e-learning initiative is to enhance the quality of HIV education, to increase the number of healthcare professionals with the capacity to treat, manage, and competently care for people with HIV. The effort is to be accomplished by integrating the National HIV curriculum into the training curricula of health profession institutions. The curriculum is a free e-learning educational tool with the goal of providing ongoing, up-to-date information to healthcare providers who need to meet the core competency knowledge for HIV prevention, screening, diagnosis, and ongoing treatment and care. This self-paced curriculum is solely available via distance-based technology and provides 6 CMEs when successfully completed. A certificate is also provided. It includes the 6 modules that are seen on the screen, each representing a different core competency identified as essential by HIV experts. The curriculum also provides updated training information and national guidelines, as well as recommendations for HIV infection prevention and treatment, and is intended for novice to experts in the profession. It is also ideal for health professions programs like the one we're using to use in order to prepare our students to medically manage people with HIV. And notably, graduate and residency programs may also participate. This slide shows the broad, diverse geographical reach of our nationwide project. Now in our second year, our program is supported by 18 partners and 28 programs. In year 1, we had 14 partners and 22 programs. Our partners include our 4 HBCU medical schools, our 2 HBCU dental programs, 4 HBCU pharmacy schools, and 8 HBCU nursing programs. We wrote this grant to strengthen the clinical workforce for our HBCU communities. Now, prior to beginning the curriculum integration, we conducted a partner readiness assessment. The results yielded this. Of the then 24 programs, only 2 reported ever using any form of telehealth technology in the classroom. And I want us to realize that this was just 18 months ago. 11 of the 14 programs reported that their institutions were unprepared to support their participation in the project due to a lack of IT infrastructure. And only 2 had knowledge of the learning management systems available at their institution. So we then contacted the IT department for each institution and found out that 100%, in fact, had the requisite IT infrastructure to participate. The faculty members were simply not aware. We used year 1 of the project to acclimate faculty to use the telehealth system and familiarize them with the learning management system on each of their campuses. In our discussion with our partners over the past 3 weeks, when our universities have been forced to go online, each has exalted the virtue of being a resource for their department, as they now were able to seamlessly migrate their academic work online. As such, the telehealth project has had a positive impact on our participating HBCU health professions programs. This slide shows that over the past 18 months, we've been able to educate over 1,300 students from our health professions partnership programs. And each has done some from 2 to 6 of the modules in their trainings. Notice though that the cohort, only 51 of the students are medical students. I hope that you agree that we need to boost this number of medical students, given now what we know. We recently sent marketing information about the national curriculum training to the 6 NMA region chairpersons to alert them of the opportunity for their professional members. We plan to have conference calls with the group sometime in late May. And we are pleased that retired former Congresswoman Donna Christensen serves as our lead faculty for outreach for our projects, for this particular project with our medical cohort. We've also used telehealth for our work internationally. Called the Caribbean Clinicians Community of Practice, we are supporting clinicians in 10 Caribbean island states to hone their skills in HIV and HCV diagnosis, treatment, care, and support. The goal is to help strengthen the HIV/HCV clinical workforce throughout the region. The 10 island states currently participating in this Gilead Sciences funding initiative have the highest HIV/HCV prevalence rates in the region. Now, even with limited resources, specifically the pervasive lack of electronic devices, we surpassed our goal of educating 200 clinicians during year one of this project and have more than doubled that with actually 473 clinicians being trained. At almost 52%, physicians were the highest number to be trained. With additional funding, we plan to expand the program to 8 additional islands. This is due to regional demand to participate in the program. This slide depicts our focused physician-centered marketing efforts that we'll be sending out to the NMA, and so everybody can have this to encourage you to sign up and take the training yourself. This one also shows the website and several of our newsletters that we have available. And also, this now shows you how to register to get your 6 CMEs. I want to take a minute just to talk about vulnerability in the advent of HIV and COVID-19. We know that vulnerabilities and health risks of people with HIV will increase in disaster situations. And while the impact of HIV is generally well documented and understood, considerably less attention has been given to the unique needs of people with HIV and now COVID-19 in disaster situations. We know that a significant number of the US population affected by HIV and now COVID-19 is also geographically located in areas that are prone to disasters, and as such, further exacerbates vulnerabilities to treatment failures. We also know that people who are unable to access their meds are in danger of secondary infections, and they have a higher risk of transmission to others. Moreover, emergency and disaster situations may also serve to bring populations in areas that have low HIV prevalence rates into contact with those from areas with higher HIV rates. So to prevent HIV, as well as COVID-19 from persisting and expanding beyond the disaster incident, as clinicians, I urge you, all of us, to help advocate that a response to HIV and now COVID-19 be incorporated into the overall emergency response strategy for our communities, our states, and our region. And let me close my comments by saying, the emergence of new telehealth-related capabilities and their integration into education and care delivery systems present an exciting opportunity. Not only do we consider this value-based education, but think of the return on our investments. This technology can also serve to improve clinical care, health promotion, and disease prevention. Now, we know they also present a challenge as health professionals adapt to these innovations. So let us leverage our resources, like what we have at Howard University Telehealth Training Center, and be full players in the changing telehealth landscape, while concomitantly working with our whole communities to safeguard their health. Thank you.
Thank you, Dr. Downer. We really appreciate that presentation, and I've learned a lot about the difference between telemedicine and telehealth. So we will go next to any questions and answers.
So, Dr. Kane, there's some echo in your microphone.
Okay. How is it now?
Good.
Okay. We will now go to questions and answers for any of our participants who have signed up for the webinar.
Okay, while you're doing that, I have a question for Dr. Downer. So Dr. Downer, you mentioned telehealth, and that was very informative. I appreciate that. COVID-19, to our knowledge, hasn't really hit the African continent yet hard, though my instincts tell me that it will. What is the potential for the use of telehealth for us to communicate with African physicians on the continent as it relates to things we've learned as relates to, let's say, ventilators, PPE, testing, population health? Is there any role for telehealth as it relates to that?
Definitely. The technologies that we use for the Caribbean and for the US are replicable. One of the things we also know we have, for example, is the simulation center. And I know that we can use the technology within the center to train and educate and actually to show how procedures are done. Remember, as I said before, it is really an educational tool. And to the extent that we're able to do the educational component both here in the US and in the Caribbean, this is really global. So yes, we can actually do that. One of the challenges we often have with working internationally, as well as working in our geographically remote locations in the US, of course, is the bandwidth to be able to actually take the programs there and to have them conducted. But with that said, and if that's set up, it's not a problem.
Thank you.
So the next question comes from Dr. Wari Allison, who's assistant professor in infectious diseases at University of Texas Health in San Antonio. And she's the medical director at the San Antonio AIDS Foundation. And I believe it was in Dr. Brown's presentation that what's the risk for HIV severity in our HIV patients with the coronavirus? Because we know that at least 50% of our HIV patients are over the age of 50. And does it make a difference if their CD4 count is not adequate, but their viral load is undetectable in terms of their risk for severity of HIV illness? So Dr. Brown,
Thank
if you could comment on that.
I'm going to unpack that question a little bit. So the question is, does it matter if their CD4 count is lower or under, in this case, under 500 or under 200, but their viral load is undetectable? Your CD4 count certainly plays a very big role in terms of your risk for the other infections that come along that can with HIV infection that can then be qualified as AIDS. And it depends upon how low your CD4 count is. That's one part of the answer. Then the other question I think that was asked was in terms of the severity of HIV and the severity of COVID. Well, we know that if you have an undetectable viral load, and if your CD4 count is adequate, meaning your CD4 count is 500 or more, then we think that the risk with your presentation in COVID is no different than the rest of the population. We're not seeing a large ton of HIV patients who are acquiring COVID and doing worse. That said, remember, we've only been at this in terms of data collection nationwide for about a month. So there's still a lot of data that needs to be collected and a lot of information. So we're learning on a daily basis. And in Spain, which has been seeing the epidemic for a bit longer and doing research a little bit longer, particular projects looking at HIV patients and comparing them to HIV uninfected patients to see what their rate is for acquiring COVID, but also seeing how they do. So we should have that data in the coming many months. But I think this is so difficult a situation that we're all in that we really want lots of information, but we have to remind ourselves we've not been at this for very long with this pandemic in the United States, and so there's a lot of information that just isn't available yet. I hope that answered enough of the questions for you.
Thank you. Then the next question is, we heard how Gilead had kicked off this new collaboration with the Centers for Disease Control and Prevention and really trying to be one of those critical parts for ending the HIV epidemic. And so is anyone concerned or worried that because of this coronavirus epidemic that's taking place, that the monies that were going to be directed for eliminating HIV or eliminating it are you concerned that the federal dollars may be focused over to take care of the coronavirus epidemic? I don't know if that's Mr. Brooks. Can you address that question?
Sure. The answer is I don't know. I think it's a very good question because we don't have an inexhaustive supply of funding, and at some point we're going to have to look at budgets. I will say to date, we've not heard that. And I do really believe, I truly believe that the administration, I know the CDC and HHS are very committed to this. I do know the work continues, and that the team at HHS is moving this along. So I hope not, and it's an opportunity, to say, as we're thinking about all of these things, we need to think about the policy issues as well. And it's never a bad thing to call one representative or senator and voice one's opinion. I'll stop there.
So then now that people are living longer with the treatment that we have available now, so that we have a larger number of people from a prevalence standpoint in this country. So, Dr. Downer, when we look at the workforce, and you kind of alluded to it, it looks like we're going to need more HIV practitioners, whether it's physicians, nurse practitioners, physician assistants, and others. Is there a concern, and is there some kind of way how we need to start increasing our workforce, especially in our communities?
Yes.
Where we may have a lot of people who don't have insurance, okay, may not be able to have access to health care. And so how do we reach them?
Mm-hmm. Well, Dr. Kane, as the federal government's data show, as I mentioned, there's about a 30% drop. We need at least 30% more increase in our clinical workforce. And this particular project, the integration of the HIV curriculum into learning systems in academic institutions, is one such important approach. If you remember the slide I showed, that we need to increase our physicians. So our nurse and nurse practitioners, our pharmacy, dentists, and allied health, which includes clinical social worker, clinical case manager, OT, PT, speech, nutrition, and respiratory therapists are all taking this training. And what it's doing is saying, that you haven't had this training before, we've got to get it so that you know what the treatment modalities are, what the treatment approaches are. And because we have the cultural competency is so key, because getting the didactic and the hands-on clinical training, it really doesn't do well unless it's couched and presented in a cultural milieu of what we're looking at, right? Cultural competence is the ability to work effectively across cultures. And when you think of the number of immigrants that are coming into the communities as well, that becomes critically important. So we need to make sure that our communities are trained, educated, and trained. And one thing some of you might have heard me talk about over the years is we've done some research into our foreign trained medical graduates. I mean, many of our international medical graduates are coming into the communities that need them. The service provided is important. But if someone comes from a totally different culture into a community and does not understand that community, you can see where there becomes a challenge. And I'll give you an example. We had an opportunity to work with a group of clinicians, physicians, they all were, and their practices were different. And we remember one of them saying to us, you'll send us into these communities to take care of these people. And I met this woman, and she has 3 children, and they're for 3 different men. In our culture, we would not see somebody like that. Now think about what she just said. Another one said, in our culture, men who have sex with men, that's a capital offense. We kill them. But you're asking me to go into culture, in the community and provide training? We have to not only provide the academic piece, but the cultural competency becomes key. And this particular curriculum, integrating the national HIV curriculum into existing curricula, that is one of the first steps that we can do that. And because it is electronic, we're using telehealth, it is self-paced. You can do it at your own leisure. Just get it done.
So my question to the next caller is saying, are we currently tracking the number of HIV positive persons who have died from COVID-19?
I don't know that nationally in the US. I think there's going to be a lot of work that'll end up happening retrospectively, meaning looking back, because in the cities like New York and in Louisiana and in LA and other places around the country, this has been so fast and so furious and only just starting to slow down in a few places. I think there's a lot of data that hasn't been picked up in a prospective fashion, but we'll be able to look back later. So I'm guessing no, there are probably some researchers who are doing this in a sort of quiet fashion, but as a whole, I'm guessing no, and we'll end up looking back. Again, I know in Spain, they're actually doing this in a prospective fashion, but that got started as their epidemic, again, started to slow itself down a little bit.
So I do know that at the start of the epidemic, there were only 8 states in the United States required demographic data. 8 states only at the start of the epidemic. And so whereas we might have information on the number of HIV positive people, and although African Americans make up, I guess, nearly 40% of all the HIV occurring each year, we just might not have it broken down by demographics, but just the total number of people who may be HIV infected. But it all depends on, do they even require information about what chronic medical conditions are associated with the people who die. And like you said, being able to go back retroactive to get that information. Dr. Downer, it says, what do you see as the role of the RD in approaches for optimizing HIV prevention and treatment?
The RD means a registered dietitian, and food is always important. Food, healthy, nutritious food that is handled safely is a critical component of addressing not just HIV, but all health diseases. So the role of a clinical dietitian, someone with expertise in HIV, is part of a significant team and can help to not only support the culture of the person's diet and their preferred foods, but also how it's prepared, how it's stored, and how it's handled. So the registered dietitian plays a significant supportive role in her patient's care.
Okay, Dr. Kane, I have a question for Mr. Brooks, who does have an honorary doctorate, I might add. So, Douglas, something you said struck me. We are and clarify if this is accurate, we are 5.9 times more likely to be incarcerated in the U.S. So my concern, and this is part of our joint statement with the Rainbow Push Coalition and with the National Bar Association, how will that in your mind, I know you're monitoring and an expert in HIV, but how might that end up affecting the incarcerated population as relates to COVID-19?
I wish I had a better understanding of it and idea, but if we just look at if we look at infection and the things that we know about this, if there are more Black people in these crowded spaces, which we know is a fact, we know that the spaces are crowded, so people are in closer contact with each other. We know the importance of social distancing, so that's not happening. We can't imagine, don't know for sure, but we can imagine that there is little to no protective personal equipment. And so all of the things that we are being told to do to prevent COVID-19 are not available to people who are incarcerated. And so if there is any, if the infection is there, if the virus is present in the setting, it only suggests that there would be higher rates of infection. Does that make sense as an argument?
Unfortunately, it makes perfect sense. So thank you. Turn it back over to you, Dr. Kane, unless you have any comment on that in the prisons, because we are very concerned, and there are cases in the prisons, clearly, and there are actually some prisons, there are more jailers with the infection testing positive than actual the incarcerated. So we're very concerned about that.
So it's a major concern, and you have a sort of like a finite number of individuals in a prison, and the things that we always worry about are things that we see. What happens sometimes is because of costs, there's not always the level of expertise in medical care for someone who's HIV infected. So we would sometimes, quite frequently, have people on a regimen that's not the appropriate regimen because they haven't done any resistance testing. And so they're on medications that are already resistant to this medication, and it doesn't benefit the patient. But sometimes even when you have discussions with a medical provider that's over a correctional facility, they won't change because their formulary may not contain the kind of medications you need in order to treat people appropriately. And, you know, it varies in different communities, different cities, and different states. But that's a major concern, making sure that we have qualified folks who are able to manage HIV, or if they don't have that expertise, have a referral system with that level of expertise, reviewing the treatment for our patients, but more important than that, providing prevention medications prevented from happening in our correctional facilities, because they may only just do one test during that time, just when they're coming in, but they don't even do a follow-up test before they leave. And that's making the assumption that, you know, no one's having sex in our jails. So what can I tell you? So I'll move on. And this is a comment by a participant wanting to know, what is the process to introduce Dr. James E. K. Hildreth, President and CEO of Meharry Medical College, to the panel for future discussions on HIV and COVID-19. He's been a long time NIH researcher for, I want to say, at least over 15 years, a PhD and MD, Rhodes Scholar. He started the HIV Healthcare Disparities Clinic at Meharry, which consists of a medical, dental, and research graduate school. And so we will definitely continue to have more webinars related to this subject. And we would be honored to have such a premier HIV research panel member be your participant in providing communication and education across the country. Now, honestly, I will be biased because he's from Arkansas and I'm from Arkansas. And also my co-chair for the HIV infectious disease section for the National Medical Association is our own Dr. Wilbur Jordan, who's director and founder of the Oasis Clinic, one of the largest predominantly African-American clinic in Los Angeles, California, and an associate professor of medicine and internal medicine at our Charles Drew School of medicine. So always honored and delighted to get more involvement with our medical schools, such as Dr. Downer from Howard University. So we look forward, Dr. Brooks, to having future webinars related to this subject.
Yes,
Now, I have
yes,
another, yes, I have another question, and that is, do we foresee community-based organizations who test for HIV being able to add the capability of doing tests for COVID-19? Any panel member can answer that question.
Hi, this is Golda Downer. I don't see why not. I don't see why not. I think that for example, I am a medical reservist for Washington, D.C. So I've been trained to do the nasopharyngeal swab. So if a clinic is going to be offering HIV testing, the staff just needs to be adequately and competently trained and prove that they are credentialed to do so and can follow up. As I think Dr. Brown said earlier, it's just like we are supposed to routinize HIV testing. This potentially is going to be routinized at some point in time as well.
Now, I don't know what the issue is across the country, but I was only just this week able to get additional COVID-19 testing collection kits because there's a shortage of nasopharyngeal swabs. My public health laboratory, which my instrument cost over $60,000, I'm told I can't even get reagents until the 1st of June. So I do want to caution individuals that in certain states and communities, we may not yet have the availability of the COVID-19 testing that we need to have. Next question, really quickly.
Actually, can I comment on that?
Yes, please do. Please do.
Yeah, the other thing to be really wary of is there are lots of different tests out there. And to make sure that the test that you are using has good sensitivity and, more importantly, good specificity. So pick up a person who's negative, you know that they're actually negative. Because there are a lot of different tests that have been released without necessarily being adequately reviewed by the FDA.
Well, on that question, I'm going to give another follow-up question, and this is from Dr. Wari Allison, again, who's the San Antonio AIDS medical director and on the faculty at University of Texas in San Antonio's infectious disease division. And she has a question about the antibody testing. She says there's a lot of talk about COVID-19 seroprevalence, antibody testing surveillance, and she has concerns about how this information can be used in a negative way in minority communities if identifiable data are collected. For example, identifies for those who are undocumented, or as it may be used as a reason not to let people go to work. For example, it may be taken as an indicator of no immunity. And so you might be at a much higher risk for the coronavirus infection. And she says she'd be interested in the panel's perspective on this. So I don't know who would like to respond about how, if you did antibody testing, which would mean you may be able to go back like in January and you might have had flu-like symptoms and you didn't, but your flu test was negative and your doctors couldn't figure out what this viral syndrome was. And so an antibody test may be able to detect you've had a past infection a number of months ago. So what do you think? You might give our panel faculty, anyone have any perspective on this?
This is Gina Brown. Just like the tests that are available to determine if someone has COVID, there are a bunch of different antibody tests that are out there. Different hospitals are making their own. Again, we need to know, one, that they are accurately picking up antibodies, and you also need to know whether they're picking up appropriate antibodies. Are they picking up IgM, IgA, which may pick up someone who's actually currently infected, or are they picking up IgG, where you would have someone who's previously been infected? And then the other thing we don't know yet is how long the antibodies last and whether or not the antibodies are actually protective. And so I think we're jumping the gun to think of using this as a way to determine who goes back to work or who doesn't. And because one, it may not be a great test and may not pick it up. Two, it may get the wrong antibodies. And three, antibodies we don't know necessarily guarantee that you're protected.
And I think that's excellent information, Dr. Brown. We just don't know. The key is the last one. We don't know if the IgGs are protected. We don't know at what level there's protection. We do not know how long, if it does protect. So, Dr. Kane, do you have, we're close to the end of our time. Do you have one final question for each panelist? Or would you allow them a closing statement?
I've got just really two quick questions that I think are important. So this is from Derek Butler, one of our leading infectious disease physicians in Los Angeles, and has been a wonderful co-chairperson for our last HIV program that we had in Hawaii. He says, any thoughts on the early opening of southern states from COVID restrictions when the South has the highest HIV rates? Any thoughts related to that? Any panel member?
I have thoughts, but I want to keep my job.
Then here's my next question right quick. Currently, there's 649 federal inmates and 336 staff in federal prisons have tested positive for COVID-19. Are there any approaches or thoughts in terms of how we may need to handle that? Any panel member? Well,
please. I will say that's new information to me, but it's information I'm glad to have. And I think, and this speaks to this webinar and the partnership, there are opportunities for private-public partnerships in this area, and an organization like the NMA, I think, has the power and credibility to raise these issues, and to see what we can do about it.
So yes, so a number of our NMA members in our local communities are looking at ways. We heard in Ohio, when a prison system, 1,900 inmates were positive for COVID testing, which could be possibly definitely creating a higher risk for the other negative inmates. So some of us, and this is not the opinion of the National Medical Association, this is just an opinion from myself as an infectious disease expert, I think we could be encouraging early release for individuals who are non-violent offenders, and they may have like a month or so to go. We're in collaboration with your judges and judicial system and law enforcement. You can make those decisions and discharge patients to home detention with GPS monitoring on their extremities, where they can't live or walk past a certain area. So that's just one consideration, but we got to make sure that testing is accessible to all our correctional facilities if people become symptomatic. So I will stop right now and would like to ask for each speaker to just give me a few minutes and last remarks before we close the webinar. I will start with Mr. Brooks. And Mr. Brooks, if you could you comment on the cost of our medications, and can our low-income vulnerable populations have access to that medication?
Sure. So first of all, Thanks again for hosting this session, and I'm very honored to be on a panel with two brilliant Black women who I've known and respected for a long time. And if I may, I'd like to give a shout out to two of my Gilead colleagues, Deborah Wafer and Keisha O'Reilly, who helped us develop this partnership with NMA. And I'm glad you asked about PrEP because there are a lot of misconceptions about access and price. Well, there are no absolutes. The data show, including from CDC, that cost is really not a significant barrier for most people in PrEP. There are a range of, for people who are insured or underinsured, we have programs. We, Gilead, as the manufacturer, have access programs. We also, you may know, we've just donated a significant donation to HHS for the President's Ending the HIV Epidemic Initiative. In fact, we gave enough for 200,000 patients. It's an extended, for an extended period. I'm embarrassed that I can't remember the exact end date, and maybe Gina does, but it was for over 10 years. I think it was 11 years. And so we, I would be careful here. Cost should not be a barrier for most people. And when people do encounter cost as a barrier, you should take a look at our access sites, and we can get that information to you at NMA to distribute it to your providers, and I commit to doing that.
So, Dr. Brown, people have wondered about, with your huge research background, should we be encouraging our people of color to participate in clinical trials to gain the knowledge about how PrEP or other medications impact our active infections?
Absolutely, absolutely. I think it's incumbent on us. If we want to know how this works with us, then we need to be willing to, we have to participate in clinical trials. And I actually would take that participation from more than one level. It's the people who are participants who are part of the trial receiving the experimental medications, which by the time you get to the point of enrolling people in large numbers, they have been well studied in people in smaller numbers to really minimize safety issues. But we also need to do a lot more work getting our next generation of researchers, clinicians involved in research, making sure that the brilliant minds that are at Black and African at HBCUs are involved, making sure that our folks who are not also have access to mentors. And then we ourselves, if we're working within a university system, willing to be the mentors to make sure people get the information they need to start to build research careers.
And Dr. Downer, I will give you the last leading remarks in terms from your perspective, what should we be doing in our communities of color?
I think the three things that need to happen to achieve greater success at the national and, dare I say, global fight is we must dramatically reduce new infections. We must achieve viral suppressions in those already living with the virus, and we must get an accurate count of the disease burden in our country, and especially in our communities that are hardest hit by these diseases. And then we must ensure that a culturally competent approach is included in the care plan. More than 30 years into the HIV epidemic, the disease remains a quandary of exceptional proportions for public health, and we must move from crisis to control. We must use the tools available, like telehealth, to alter the course of this and any other emerging pandemic, such as COVID-19, and then control it. Telehealth and the National HIV Curriculum are two resources our communities can use together to work to increase the number of competent HIV healthcare providers. The bottom line is simply this: an infectious disease threat anywhere is indeed a threat everywhere.
So listen, I just want to say what an incredible panel, and I want to commend for getting this critical information out to our clinicians and other community partners and participants. This was such an enlightening perspective and looking at these solutions that we can put in place. And we have the ability to make an impact in our community. And so I just want to thank this outstanding panel, and I want to thank our NMA President, Oliver Brooks, for taking the leadership and the lead on making sure we're addressing the issues that impact our communities, because this COVID-19 has put a shining light on the social determinants and how it impacts our HIV patients. And so I will have our president give closing remarks, and I'm delighted and honored to be part of this panel related to my also my co-chair, Dr. Wilbur Jordan, co-chair for our HIV section. Dr. Brooks.
All right. Yeah, thank you very much, Dr. Kane, for moderating this excellent panel of presenters, Dr. Gina Brown, Dr. Gouda Downer, and Honorable Dr. Douglas Brooks. The information shared was very informative, and I just want to underscore one thing that I believe as Dr. Brown said. If you get your CD4 count above 500, your viral load undetectable, you are just now at general risk. You have eliminated your risk, elevated risk of having HIV and COVID-19. So with PEP, PrEP, or treatment, you get yourself under control. And the studies are also showing that if you have diabetes or if you have hypertension, which puts you at higher risk, if you get those under control, you lessen the potential for an adverse outcome from COVID-19 and asthma. So it's a clarion call to take care of yourself. When we refer to HIV, take your medications, have the knowledge, prevent it, or if you have it, treat it. Take care of yourself, stay and get well. In closing, during these challenging and uncertain times, the NMA plans to continue to be a source of scientific, like this, and practical information to keep you and your family safe. COVID-19 is real, and I think we understand that, and it will only be what someone referred to me as tamed by continued heightened vigilance. Follow all preventive guidelines for infection control, and use common science sense. Seek information from local and state health departments, like Dr. Kane's in Indianapolis. Take your lead from the scientific community. And importantly, for NMA physicians, stay informed like you are being informed today. You are the community's source for guidance. Patients trust their doctors. We both must follow the science and lead our community. We are the leaders in our community. If we don't lead, then who will? So again, I want to thank everyone for attending this webinar today. And there will be more webinars, Saturday webinars, sponsored by the NMA in the future. So thank you again, and this webinar is now